just want to, first of all, thank Aware for allowing me to come back again and harass you all. I was here last year on a different topic. People have asked me why I did history in third level, and I simply answered that was in order to avoid my own history. So some of you may know that I have my own personal history of dealing with the mental health services since I was a teenager, but we're not here tonight to talk about that. We've done that. The tragedy's over. I want to comment on the terminology. Because this is history and I'm going to be talking about sources that are 100 years older or older, there are certain words that are going to come up that are in the sources. So you're going to hear lunatic, you're going to hear insane institution, asylum, different things like that. So don't be panicked. As historians, we use the terminology that was used at the time and in the sources. In the 1700s, treating insanity in the Irish population, and particularly in the poorer population, was part of a wide process of reform undertaken by authorities, which attempted to improve Ireland's moral, social and economic problems. However, providing services for the insane was not straightforward. A plethora of social issues existed, making it harder for authorities to divide poor, destitute, criminal and mentally ill into separate groups requiring specific types of services and supports. As time progressed, it became increasingly obvious that the insane in Irish society did not have a separate voice in the reform process. Roy McClelland has argued that vagrancy, drunkenness, witchcraft all tended to disturb the social and religious order and demanded restraint. To help maintain this process, a public policy developed of incarcerating the non-conforming, the nuisance and the insane, as well as the criminal. Little distinction was drawn between them. This lack of distinction meant that services for the insane were incoherent and inconsistent across much of Ireland before the 1800s. Early reformers achieved one important change in the 1800s in Ireland. They made distinctions between vulnerable groups in society. Those who were insane were not automatically criminal. Those who were poor were not automatically insane. Those who were destitute were not necessarily criminal, insane, or beggars. Intellectuals tried to shift attitudes away from the assumption that those who were less fortunate than others were consequentially more evil. The most obvious evidence which suggested this was the establishment of institutions for the insane, prisons for criminal cases, and workhouses or houses of industry for the poor and destitute. In the 19th century, these institutions showed an overlap of cases, which meant that institutional support simply lacked sophistication in an Irish context. However, the way in which the institutions were used or misused over the course of the century cannot change the fact that reform in mental health care was achieved by authorities. The 1800s was characterised by the construction of a network of public asylums and a substantial rise in the amount of inmates in those institutions. Although there were many factors influencing the rise in patient numbers throughout the century, the period of famine in the mid-1800s witnessed a considerable increase in the volume of people diagnosed with a mental health issue or requiring immediate admission due to the effects of starvation on mental health. Effectively, the asylums became a theatre of despair and hopelessness during the famine period, much like the workhouses across Ireland. The utility of madness was equalled only by widespread death and deprivation occurring outside the asylum walls. The asylums did not offer hope or protection from starvation or death. They merely offered an alternative space on the landscape for individuals to experience the full effects of the famine. As a result of such experiences, the practice of institutionalizing the mentally ill had become firmly rooted in the Irish psyche. In fact, one could reasonably argue that it is a misconception that Ireland witnessed an epidemic of insanity in the 1800s, but rather a concentrated wave of institutionalization occurred, which was brought forward into the 20th century in various forms and guises. By the end of the 1800s, the local government system came into effect, which transferred power from the grand juries to county council, significantly changing the political landscape of the country. The Local Government Ireland Act 1898 embodied the new beginning envisioned for the 20th century. It was the most important piece of legislation to come into effect for the mentally ill because, among its many rulings, it had legislated for the future development of mental health care. The Act gave responsibility for providing or improving health services to locally elected representatives on the newly constituted county and district councils. On a wider scale, the Act was introduced by the British government to improve the machinery of self-government modelled on the existing system in England. The introduction of local government was also an attempt to calm social and agrarian unrest and quell calls for Home Rule, which had created tension between Unionists and Nationalists in the decades prior to 1898. Reform on a political level was equal in significance to reform of public health care based on the interests of the electorate and the election of politicians who represented those interests in the local government system. The Act changed the professional status of staff in institutions for the insane and union workhouses. In particular, the new system ensured that only qualified officers and nursing staff would be allowed to work in such institutions. Nurses and attendants were expected to obtain a recognised qualification of proficiency from the Royal Medico-Psychological Association. Every resident medical superintendent, or RMS, had to be a legally qualified medical practitioner of not less than 7 years' experience in a recognised institution before taking up this most senior position. Qualified nurses were paid 1/2 of their salary from the local taxation account. The RMS's salary would also be paid out of the local taxation account. This meant that salaries, in part or whole, were paid regularly and in line with local government regulations. I'll just explain the reasoning behind that. It's not out of context. It's quite innovative. Back when they were trying to reform the prison system in the 18th century, when you had John Howard, Lord Shaftesbury, one of the main points that they saw as stopping abuse was to actually ensure that staff and keepers were paid in the institutions. It was a way to kind of buy their loyalty, their responsibility within the institution. So when the local government system came into effect, the same type of ideology popped in to the Irish system, where in order to stop abuse, to improve the quality of care in institutions in Ireland, they saw it as, we have to make sure that the staff are paid regularly. And in order to do that, it's coming from the local taxation account. That was the simple reasoning. This new relationship between local councils and institutions meant that the haphazard approach experienced in previous centuries quickly evolved. It was hoped that properly trained staff would raise institutions from the mere custody of patients to hospitals with more emphasis on recovery. This was a progressive step in terms of institutional mental health care in this period. Local politicians did not have to have any training in mental health care. In fact, they didn't have to have any knowledge either. They merely regulated the employment of staff and raised the professional standard of institutional care. When councils received reports of overcrowding and unsanitary conditions, this gave them a political and moral obligation to improve the system of care in the best way possible for patients. Not so sure obligation, it should be responsibility. It was their job. But the councils did face challenges on many fronts, and we'll talk about a few of those challenges now. The official records in the early 20th century showed an increasing patient population and a rise in physical illnesses among the patient population in the early 20th century. Death from disease, overcrowding and unsanitary conditions were serious issues. The record showed a rise in the level of zymotic diseases in district lunatic asylums. Zymotic diseases were infectious maladies such as dysentery and typhoid. The number of inmates increased over 50 years from just 10,000, according to the inspector's reports in the late 1850s, to over 25,000 in the 1901 census. In response to overcrowding, a number of asylum committees and county councils planned to expand facilities, but it proved difficult. And I'll explain the reason why it proved difficult for them. When the local government system was established, before independence, the county councils and district councils were under the authority of the local government board, which is called the LGB. When independence was achieved, or nominal independence was achieved in 1922, this became the local government department. A lot more was achieved under the department than the board. So Cork, Maryborough and Cavan county councils all tried to expand facilities, and there were provisions made in the Local Government Act that gave them a pathway to reform services, to set up small auxiliary asylums, but the Local Government Board wasn't having any of it. In this period, the belief from previous centuries that insanity was a moral and deliberate choice had been usurped by medical science. Increased knowledge on mental illness moved the language of psychiatry quickly from the moral and religious arena onto the clinical stage. The emergence of explicit terms such as paranoia and degenerative psychosis, crafted by Kraepelin, Kraft, Ebing and Spitzke, advanced the agenda of psychiatry in the Western world. Psychiatrists gained confidence in the political and public arena and expressed concerns regarding the power of lunacy laws in Britain and Ireland. For example, in May 1904, a debate ensued in the British Medical Journal over the progress of medical knowledge with regard to insanity and the law. One contributor stated, "In no branch of science had there been greater progress during the last generation than in the knowledge of the brain and the central nervous system. And whereas when the lunacy laws were framed, they were based more or less on the view that the case of a person of unsound mind was hopeless, and their main purpose was to protect the lunatic from ill treatment and the public from the lunatic." Institutional care was a contentious issue for practitioners. On the one hand, knowledge on insanity and treatment was expanding, but on the other hand, the lunacy laws assumed that every case of insanity was hopeless, thus confining a person indefinitely. At the same time, asylum authorities believed that the most urgent issue that needed to be addressed was the level of overcrowding in facilities and spread of disease as a result. The advent of modern technology offered some hope in this regard. For instance, the introduction of electricity meant that fan ventilators could, in time, be used in asylums. The air in dormitories would be cooler as a result and reduce the spread of disease. As everyone knows, that viruses and diseases like somewhere warm and cosy. The establishment of Portrane Asylum in North Dublin was a significant step forward in terms of sanitation discourse. And sanitation discourse was happening all over between Britain and Ireland, really from the 1870s. There was a Public Health Act in 1870, as far as I'm right, it could be 71, but it was about this, making Ireland a healthy house, making Britain a healthy house as well. So all forms of institutions, making them healthy. Portrane was constructed close to the sea, thus providing a natural and cost-effective way to ventilate the buildings daily. It was designed using a broad echelon or broad arrow plan, spreading the institution outward along the coastline, which provided greater movement of air around and through each section. I'll just explain the architecture of it. The early architectural forms were more like panoptic, so they went up or they went round in a square. But when Portrane was built, it was modelling really the American architectural styles. It went this way. So it went out, so the air was coming, so it wasn't going back as far, and it wasn't going up. They were causing difficulties. Portrane was considered a hallmark of modern mental health care, certainly in its first years of operations. Of course, it all went to pot. Now, the difficulty, or the thing that was happening at this time, was that county councils, politicians, healthcare professionals, everyone trying to establish themselves in a mental health service, were managing expectations. They were always constantly managing expectations of the public. So back in 1817, when they made a plan to build lots of institutions, that was the managing the expectations of the public. Lock them away, keep them out of sight. But in the early 20th century, that had changed. There was people who were looking for more holistic forms of care. They were looking for a more caring environment and better treatment. Advertisements appeared in the papers. On one advertisement, you may recognise the name of this place, a new hospital for mental diseases opened at Lucan, County Dublin in 1904. The hospital was intended for the curative treatment of mental diseases, located on a domain of over 200 acres. It was equipped in the most thorough manner and provided with every facility for the successful carrying out of its mission. St Edmundsbury's was a hospital for ladies and gentlemen suffering from mental complaints at moderate rates, varying with accommodation required. The facilities included separate apartments, handsomely furnished, and commanded attractive views of river and mountain, with extensive grounds and woodland. Voluntary boarders could be received at the hospital, and the Lucan tram from Dublin passed the gate of the institution hourly. It also had a telephone system in the institution, and all sanitary arrangements were modern and up to date. In contrast to the Lucan facility, public asylums built in the 19th century caused much concern for politicians and healthcare professionals. A fatal disaster threw the failure of asylum buildings into public disrepute in 1903. Connolly Hatch Asylum was located just outside London City beside the Great Northern Railway. It opened in 1851 and had a patient capacity of over 1,200. A fire broke out at 5 a.m. the morning of January 27th in the Jewish wing of the asylum. Over 50 female patients died in the fire. The flames ripped through the wooden structure and trapped many old and infirmed women. The windows were barred, preventing escape from the institution, and as a result, the fire. One report noted that feeble women were seen struggling fiercely to break the bars, at last being forced to fall back and perish in flames. No staff died in the disaster. A number of aspects of the tragedy were discussed in both Britain and Ireland. It was actually this tragedy went as far as Tasmania in Australia, and it went to the US, it went everywhere. Firstly, authorities noticed that it was difficult for the fire service to reach the institution and access water to fight the flames. They had to pump water from the nearest river, which was 400 yards from the building, delaying the rescue considerably. In Ireland, authorities responded to this issue. When Portrane opened, the tower at the front, if you know the architecture, doubled as a water tank in case of fire. Usually it was a bell tower or a viewing point for the RMS. Institution committees met to discuss measures in place in the event of a fire at an asylum. A number of committees connected with the local fire services and detailed plans in the event of an emergency on an asylum site. Other institutions made their own fire service available. For example, in Monaghan Asylum had its own firemen with equipment and access to water to fight a fire. They even had fire clothing with the institution name engraved in it, and I've seen the helmets up in Monaghan Museum. They have, initially it was, the initials on it were MLA, which is Monaghan Lunatic Asylum, and then the later ones, you can always tell the timing, are MMH, which is Monaghan Mental Hospital, and I'll explain that in a minute. The question of bars on windows was discussed extensively by councils and committees. They had to find a balance between protecting the patients and protecting the public. Bars on windows acted as a symbol of the challenge to change from the traditional asylum rhetoric, which was paranoid, to modern healthcare, which was progressive. Another failure highlighted by the fire in the London asylum was that the patients were so institutionalised that they could only exit by the door they used each day. This meant that the staff who tried to save the women could not get them to leave by an alternative exit. Members of professional associations in Ireland and Britain believed that all patients had to be made aware of other exits and be made use those exits regularly so that if a fire broke out, they could be led away from danger. The construction materials used in asylums were discussed. For example, the asylum buildings were erected with timber frames and lined with boarding, which caught fire very quickly and made the flames spread more rapidly. The tragedy made the public aware that many asylums were hopeless death traps. In the United States, frequent fires occurred in the wooden parts of asylums and institutions. The construction of wooden buildings on asylum sites was prohibited across the United States by the end of the 19th century. As the first years of the 20th century progressed, Irish authorities realised that the wooden structures on asylum sites used to house patients needed to be rebuilt with stone and concrete, Well, the initial thing of why were they using wooden buildings in the first place? Well, cost effective. And if you look at the asylums around Ireland, you'd probably disagree and say, well, they're not wooden. No, the aesthetic on the outside, the exterior aesthetic is stone. There's limestone cladding, there's granite, but the furnishings on the insides were wood. The staircases were wood. Any of the outhouses were wood. Many of the extensions, when the overcrowding was happening, they built them as wooden to get them up quickly, to make more space. So there was a lot of wood on the sites. It was not just the material used in the construction of asylums that caused concern in this period. Many fires had started in storage areas or laundry rooms due to the concentration of heat and combustible materials. As a result, Irish authorities added a concentrated fire, which was an early form of health and safety, to the service agenda, a fire discourse. Following on from the example set in the US, insurance companies in Ireland offered policies to county councils. Interestingly, the insurance policies covered fire damage to buildings, not loss of life. This period showed a heightened awareness of the failures of the system in Ireland, both on an institutional level and in delivering quality care to patients. However, the Irish government produced one example of progress. The Ardee Mental Hospital opened in November 1933. It was the result of over 100 years of authorities learning from mistakes and attempting to build a better care system for the mentally ill. I've just selected 5 points to bring out about the Ardee Mental Hospital, but there's quite a number. So the first one is, patients from Louth were previously treated in the Richmond Asylum in Dublin, just up the road became Grange Gorman. The argument made at that time by members of Louth County Council was that this was unfair to patients and families, expecting them to travel to Dublin. Remember, the road system's not fully working then. We didn't have an M1. A closer asylum was more humane and morally justified. A small local facility could be managed by the council in terms of admission rates and conditions. This gave the patients a better chance of receiving a high level of care. The cost of providing the local service would come directly from the local taxation account, allowing the council to monitor and regulate spending while implementing new and progressive care strategies. The building was a fine example of modern institutional architecture. It was constructed using brick, concrete and steel, replacing wood and corrugated iron. As such, authorities implemented the fire safety strategy. The windows did not have bars on the outside. It was built as a 2-storey, flat roof structure with access to the roof and grounds on each ward wing. The laundry building was separated from the main hospital structure, moving hazardous and combustible material away from the patients and the hospital. The ward system was strictly organised with division on the basis of gender and category of illness. The overall impression of the hospital was non-custodial, as opposed to the 19th century custodial or prison forms. This is a little known fact. The facility was the first in Irish history to be legally called a hospital, not a lunatic asylum. The structure stood as a symbol of progress in independent Ireland. I don't know if many of you are aware that it was the 1925 Local Government Act, the Amendment Act, that changed all the names from lunatic asylum to mental hospital. And so every time you're talking about a facility pre-1925, you should use lunatic asylum. Anything when you're talking about a facility pre-1925, you should say lunatic asylum. Post-1925, mental hospital, because that's the legal change. The Ardee Hospital demonstrated that authorities, both political representatives and healthcare professionals, had listened to past failures and were willing to change the landscape of mental health care, bringing it in line with modern healthcare strategies in the Western world. Although efforts to build a modern mental health service in other parts of the country faced impossible obstacles, economic factors played a significant role in the development of the relationship between asylum authorities and county councils in the early part of the century. And this is just the final part I'm going to share with you. This is what I'm working on currently, trying to write this. So I'll give you an insight into it. In 1905, the issue of chargeability, which was paying for care or who's footing the bill when you're talking about a full public health system? Who's paying? The chargeability made an appearance for the first time since the introduction of local government. Requests for the deportation of patients in public institutions abroad, such as the United States, were received by Irish authorities. In fact, official requests were not always made. In some cases, people arrived at Cork and Derry harbours off steamers who were clearly unwell. They arrived in groups of 4 or 5, the tickets for their trip found in their pockets, and background information about each person was unavailable. They also had no personal belongings with them. Authorities believed that these people were Irish citizens held in public asylums in the US who were unofficially returned in the manner described. And the question is why? Well, quite simply, the United States decided at some point that they were no longer paying the charges for a public patient who was not a citizen of their country because they were experiencing overcrowding as well. So put them on a boat, send them home. Another aspect of chargeability appeared in the county council system, but it was a domestic issue. Asylum committees wanted to find out from the local government board who should pay for an inmate from another district. For example, a patient from Donegal could be admitted to Cork Asylum and the treatment charged to the local council, that is the ratepayers of that locality. The resolution was that the rates of the patient's native county had to be used to pay the charges for the service. So Donegal Council had to pay for treatment elsewhere. It worked for everybody. And you would think that people would be happy with that resolution, but it's Ireland. We weren't. Because overcrowding complicated the issue. Asylum managers were also protective of the amount of accommodation available in their facility. They argued that local ratepayers paid for the management of the institution, but these non-local patients were taking accommodation, which technically belonged to the community. The indiscriminate admission policy in the early 20th century led to overcrowding, unsanitary conditions, and a poor level of care for patients. And I call that patch politics in the mental health system. These economic considerations continued through the War of Independence, Civil War, and the establishment of the Irish Free State. When Ireland achieved nominal independence from Britain, the issue of chargeability and repatriation of patients reappeared. Between 1922 and 1937, at least 40 cases of repatriation were organised between Irish authorities, the British government, and other foreign governments. Patients held in public asylums in the United States, Italy, Belgium, England, and many more were no longer welcome. Authorities in each institution sent communication to the newly established Irish government that repatriation was to be organised so that these Irish citizens could be cared for in their own country. The British government facilitated the return of patients on behalf of the Irish government in some cases, but it would not accept any liability in terms of the cost of repatriation or further care in the Irish state. And the main person, certainly between 1922 and 1928, who was working really as a middleman between the British government and the Irish government and the other foreign ambassadors, was T.M. Healy. This was an interesting aspect of the price of independence for Ireland. It may well have opened the new minister's eyes to the world of statecraft in the modern era. The patients who were returned to Ireland were transferred directly to an asylum and escorted, in many cases, by a doctor and guards once they stepped off the steamer. It appears from these examples that the promise of liberty, freedom and independence for all the people of Ireland, which are so much a part of the nationalist rhetoric in the early 20th century, had its limitations, or at the very least, exceptions. And I'll finish there. Thanks.